Hello everyone, I am presenting on hematological emergencies in critically ill ICU patients. So, what are the biggest hemato-oncological emergencies? There is various crises in sickle cell disease and management of transfusion reactions, TTP, DIC, and there is febrile neutropenia. There is hyperleukocytosis syndrome. In metabolic, there is hypercalcemia, tumor lysis syndrome, and there can be spinal cord compression, superior syndrome. I am mainly discussed on febrile neutropenia, DIC, um, hyperleukocytosis syndrome, hypercalcemia, and superior syndrome. Coming first to febrile neutropenia, it is the commonest hemato-oncological emergency and with mortality of more than 50%. And up to 80% patient taking chemotherapy will develop this febrile neutropenia. And 10 to 50% of patients with solid tumor will also develop febrile neutropenia. And the ANC natriuretic develops typically 7 to 10 days after the chemo. Coming to definition, it was defined by a single oral temperature of more than 38.3 degrees centigrade or two consecutive readings of more than 38 degrees centigrade for 2 hours and ANC of less than 500 or expected to fall below 500 per cubic millimeter. Now, coming to degree of neutropenia, mild is 1500 to 1000 and profound can be NH of less than 100. Now, coming to virus infection. The incidence of infection increasing as there is more intense resistance, leading to mucositis and there is prolonged or profound neutropenia. Also by increased use of indwelling catheters and bone marrow transplant patient. And the prognosis depends mainly upon the severity of illness and organ dysfunction. And it's not on the severity of neutropenia. There is mass scoring tool, which includes 8 parameters, and their subsequent values are like this. And it shows that the higher score indicating the better prognosis. Now, in there is a study in Journal of Clinical Oncology in 2015. It predicts the serious complication in patient with seemingly stable febrile neutropenia. So, to validate prognostic score, predicting major complication in patients with solid tumors and seemingly stable febrile neutropenia. The definition of clinical stability here is the absence of organ dysfunction, abnormal vital signs, and major infection. So here is their score. It's called CISNE score, which is clinical index of stable febrile neutropenia, which includes ECOG performance status of more than 2, stress-induced hyperglycemia, COPD, chronic cardiovascular disease, mucositis more than 2, and monocytes less than 200. And here, the first cell to appear after chemotherapy is monocytes. And there is three prognostic classes are there. And if the score is here is the more than 3, then there is high risk patient, though it's a seemingly stable febrile neutropenic patient. So there are various scoring tools, but it was found that CISNE is the better score and better tool. CISNE is the better scoring tool as it's coming around zero point 0.9 area under the curve. So CISNE is a valid model for accurately classifying patients with cancer with seemingly stable febrile neutropenic patients. Now, the uh, treatment part of febrile neutropenia will be discussed by subsequent speakers. Now, second is the DIC. It's a heterogeneous group of clinical pathological syndromes characterized by dysregulated generation of thrombin. That is the pathological thrombin formation, leading to intravascular fibrin formation. And there is secondary fibrinolysis also. That is plasmin generation, often resulting in hemorrhage, thrombosis, and multi-organ system failure. Coming to pathogenesis, depletion of hemostatic factors like hyperinsulinemia, thrombocytopenia, and generalized depletion of coron factors. So there is depletion of inhibitors like depletion of the alpha 2 antiplasmin linked to bleeding, and there is depletion of antithrombin and protein C and S leading to thrombosis. And also there is heterogeneous triggers of the DIC. So what are the heterogeneous triggers? There is systemic hemostasis and there is localized hemostasis. So systemic activation of hemostasis by tissue thromboplastin released by the tissue injury, and cytokines in septicemia, prothrombin activation, endothelial injury, and procoagulant platelet membranes like in induced thrombocytopenia. And there is localized activation like in aortic aneurysm and giant hemangioma syndrome. Coming to etiology, there is various etiologies, but most common will be the sepsis. But pertaining to the hematological cases, there is adenocarcinoma, tumor lysis syndrome, and acute promyelocytic leukemia. And ALL is the most common cause of leading to DIC. Now, coming to routine lab investigations, we can do CBC, peripheral smears, PT, FPTT, fibrinogen, FTPs, and D-dimers. Now, from high sensitivity to low sensitivity, from top to bottom, there is increase in D-dimer, increase in FTP, decrease in platelet count and fibrinogen, and increase in the PT, FPTT, and INR. And D-dimer is the more specific for DIC. It will be increased. Specialist test can be ordered like cause factor levels, natural anticoagulant like protein C, S antithrombin level, and paracoagulant assays. Coming to diagnosis, there is a scoring system called ISTH for DIC. It includes platelet count, D-dimer, prolongation of the PT, and fibrinogen level. And accordingly, we can calculate from the scoring system. And if it is 5 or more than 5, then it is clear cut diagnosis of DIC. And if it is less than 5, then we can repeat 1 to 2 days interval the scoring system to monitor. Now coming to the first diagnosis of DIC by exclusion of other conditions like hemodilution by bleeding or massive transfusion, TTP, heparin-induced thrombocytopenia, vitamin K deficiency, and liver failure. That must be excluded. Then coming to management, main management is the treating the underlying cause. But we can use all-trans retinoic acid in case of acute promyelocytic leukemia, and it should be started immediately in suspected cases, and later it can be stopped or continued up to confirmation. Then second is blood transfusion. Then packed RBC to infuse, keeping the hemoglobin 6 to 10 target 6 to 10 gram per deciliter. Platelets infuse only after excluding the heparin-induced thrombocytopenia and TTP, and target platelets up to 50,000 and not further. And FFP is widely used therapy, but not recommended as it causes trally. And crab acid must be infused, and target fibrinogen levels will be 50 to 100 milligram deciliter. And it is estimated that 10 bags of crab acid will increase fibrinogen level of 60 to 100. Use of heparin only in thrombotic events, and here LMWH is preferred rather than unfractionated heparin. Natural protease inhibitors. And there is troticogin alpha, which is a recombinant human activated protein C, and it's used in severe sepsis. Proves SOX study suggests that it is used in septic shock only with PAPA score of more than 25. Treatment with antithrombin 3 and recombinant thrombomodulin is recommended in DIC with organ failure. And antifibrinolytics only used in the major bleeding, particularly those with APL. And it is associated with serious thrombosis if it's used with all-trans retinoic acid. Now, third is hypoliposis. When the leukocytes count is greater than 1 lakh, it's called hypoliposis. Morbidity and mortality are due to mainly due to leukostasis. Number of leukocytes necessary for leukostasis depends mainly on the pathology, the morphological and molecular plasticity of the blood cell, and the capacity of the endothelial cell to release the cytokines. Symptoms appear mainly when it is more than 1 lakh, like in AML, but severe symptoms will develop after more than 4 lakhs. But in chronic cases like in CLL, the symptom starts only after the when it is more than 5 lakhs. Most common organ involved is brain, linked to breathing. Then lungs lead to ARDS, and rarely organ is involved organ is gastrointestinal. Coming to management, adequate hydration and pre-medication with the allopurinol or asparaginase. Hydroxyurea is 50 to 100 milligram per kg per day, which results in rapid cytoreduction. And there must be specific chemotherapy for cytoreduction. Then leukocytophoresis only in case of ML with signs of leukostasis, but use in ALL is controversial. Coming to hyperviscosity syndrome, and there is fourth class which leads to hyperviscosity syndrome. There is leukemia with hyperleukocytosis, polycythemia vera, Waldenstrom's macroglobulinemia, and multiple myeloma. The clinical manifestations, there is a triad of mucosal bleeding, visual changes, and neurological symptoms. Thromboembolic complications are more frequent in polycythemia vera. Cardiorespiratory symptoms also contribute. And coming to sequelae, there can be as leading to CHF, ischemic ATN, or pulmonary edema. Management in leukemia, mainly chemotherapy. In emergency cases, we can do the leukapheresis. And in polycythemia vera, we can be phlebotomy or aspirin can be given with hydroxyurea as cytoreduction. Now coming to superior vena syndrome, it's a complication of mediastinal tumor. It's an emergency if it is associated with laryngeal edema and cerebral edema. Most common in high-grade non-Hodgkin lymphoma, followed by Hodgkin lymphoma, then T-cell lymphoblastic lymphoma or leukemia. Coming to features, clinical features, the respiratory symptoms like stridor, dysphagia, dyspnea, orthopnea, laryngeal edema. There may be in neurological symptoms, there may be malaise, mental disorders, visual disorders. There may be facial swelling, lip edema, nasal obstruction, epistaxis. There may be vessel dilatation in the face and neck region. In treatment, urgent venography followed by superior vena cava stenting placement. Urgent radiotherapy, but it's now limited to less than 5% of cases. And medical treatment by steroids, chemotherapy, and oxygen. Now, my last topic is hypercalcemia. It is found in 44.1% of cancer patients. Most commonly develop in multiple myeloma, followed by acute leukemia, followed by aggressive lymphoma. The main contributing factor is parathyroid-related peptide secretion. Also 20% by the osteolytic metastasis. Coming to clinical features, mainly it is asymptomatic, but can be neurological symptoms like fatigue, altered mental status, posterior reversible leukoencephalopathy. And in GI, there may be nausea, vomiting, or peptic ulcer and pancreatitis. In cardiovascular system, there is mainly short QT and ST segment abnormalities, and there may be ventricular malignant ventricular arrhythmia. And in renal, that there may be nephrogenic diabetes insipidus and acute kidney injury. Now coming to management, mainly by the volume expansion. Normal saline bolus of 1 to 2 liter, followed by maintenance at the rate of 100 to 150 ml per hour, in order to obtain the urine output of 100 ml per hour. If there is not adequate urine output, then we can add diuretics like furosemide 40 mg IV. Then calcitonin 4 to 18 intravenous for kg supplements or intravascular is the second treatment option. Then coming to bisphosphonates, geranium acid, palmitoylate can be used. The main limiting factor is the nephrotoxicity. But thanks to denosumab, there is a monoclonal antibody against rank ligand. There is effective in treatment even in the refractory hypercalcemia. Advantage is less nephrotoxicity, 120 mg subcutaneous every week. But the most feared complication in the both by bisphosphonates and denosumab is the osteonecrosis of the jaw. And in all the refractory cases, you can go for the hemodialysis. Thank you.